Welcome to week 2. This week we're going to talk about evaluating risk factors as it relates to the pregnancy and what are some of the things that we can do to improve outcomes because of those risk factors. And we're going to end our lectures for this week with talking about fetal monitoring. That's our way of looking in and seeing exactly how that baby is doing in that intrauterine environment and what is he trying to tell us about that environment. In nursing school, we always talk about all the things that could happen, but it's important to start out talking about these risk factors with the understanding that a majority of our pregnancies are good, healthy pregnancies with good, healthy outcomes. With that being said, we do have women that enter pregnancy bringing in some risk factors, some that they can modify, some that they can't modify, and we're going to talk about those specifically. There are some of these pregnancies that have no risk factors coming into the pregnancy, but they develop the risk factor, and then that impacts the outcome of the pregnancy. Pregnancy complications can occur even when there are absolutely no risk factors, so we always need to be vigilant in our assessments and our review of labs and the entire environment. The reason this is important is because a large percentage of our population are pregnant unintentionally, meaning they didn't set out with a deliberate goal to get pregnant. So about 50% of the population pregnancy is unintended. They weren't necessarily trying to prevent it, but they weren't necessarily hoping that it would happen this month. And for our women who are under the age of 20, that rate is as high as 70% according to the March of Dimes. So we want to gear healthcare toward the childbearing age so that we have the better potential to have good outcomes. If 50% or higher of our women are not considering trying to get pregnant and they become pregnant, the goal is that they're already on folic acid prior to that pregnancy. That's the whole goal behind all the fortified cereals and breads and things that we talked about last week. That's to get the folic levels higher so that if these women unintentionally get pregnant, they still have a good chance of a healthy outcome, even though they may not have been taking folic acid. The reason that we care, the reason we look at these risk factors is because if we can identify these risk factors, maybe we can decrease the bad outcomes versus not intervening at all. And so part of the problem with this is access to health care. And regardless of how you feel about Medicaid, Medicare, the Affordable Care Act, or insurance, we still know that there are women that don't have access to good quality health care. It could be because of where they live. If they live in a rural facility, a rural area in Texas, they might be 20, 30 miles from a provider. They may not know about WIC and they may not know about Medicaid. They don't know how to get signed up for that, or they don't have transportation to the office to actually get signed up for that. And so they don't seek health care. And some of it is, some of the cultural beliefs are pregnancy is a healthy state, therefore they don't need to go to the doctor unless they feel unwell. And so some of the diseases that we're going to talk about over the next several weeks could cause some problems, but they actually have no symptoms that mom would be aware of that would lead her to go to the provider. How do we try to improve the system? Well, work toward universal health care that maybe not universal health care, but health care that universally covers women to have preconceptual visits, wellness visits, so that we can identify issues and get them treated. To encourage prenatal care. Now, prenatal care and preconceptual care cannot prevent bad outcomes, but maybe they can identify the issues that means that we can help treat some of those so that we have better outcomes. And then our system is set up and designed to have ongoing assessments of this pregnancy throughout the entire pregnancy so that we can identify those issues at key times when we know those symptoms are going to start presenting themselves. So why is it so important? Prenatal care, just like preconceptual care, so that we can identify risk factors early, so that we can start health promotion early. Some of the risk factors that they can bring into the pregnancy that might be modified or smoking and drugs and substance abuse, looking at those chronic illnesses or the pregnancy-related illnesses and getting those treated early. So some of the risk factors that we're going to talk about today are biophysical, psychosocial, sociodemographic, and environmental factors. We do know that things that impact the pregnancy outcome specifically are maternal age, less than 17 and greater than 35. Now, greater than 35, we consider AMA, advanced maternal age. And that means that she's going to be 35 or older at her anticipated due date. And we just know that the older mom is past 35, the more likely her health is going to be impacted by some of these chronic illnesses, which are then going to affect the pregnancy. The socioeconomic status. Does she have health care? Can she afford food? Can she afford safe housing? Race and ethnicity. We do know that there are variations in pregnancy outcome, just like there's variation in health outcomes based on race and ethnicity. Marital status. Now, marital status many, many years ago was a much bigger issue than it probably is currently, because many years ago, maybe 20, 30 years ago, if a teenager got pregnant, she may be thrown out of the house, lose any health care, doesn't have affordable housing, doesn't have a way to the doctor, can't afford the doctor. That's not so much an issue. Does that still happen? Occasionally. But we also know that we have a lot of our single women that are delivering are in very committed relationships and are very financially stable. Years ago, that might not be the case if they were pregnant and unmarried. So I think that the marital status may be losing some of its predictive value as far as health outcomes in a pregnancy. We know that gestational age at delivery is going to alter outcomes. Much more likely to have a healthy pregnancy if they deliver at 40 weeks versus a fetal status who delivers at 23 weeks. Very different outcomes in those pregnancies and for those kiddos. We talked last week about how nutrition is tied to the outcomes of the pregnancy. But interesting, is nutritional status tied to socioeconomic status? Could be. And we know we talked about smoking. That's going to impact the outcome. So what are some of the leading causes of maternal mortality? What is causing our moms to die within the childbearing year? Now, according to CDC, the number one cause of death of our pregnant women is abuse and murder. Now, when you look at OB-specific related issues, abuse and murder sometimes is not in that list. They look at specific pregnancy-induced type issues. So those leading causes would be any of our hypertension disorders of pregnancy, pulmonary embolism, hemorrhage, or infection. And you see infections in the little brackets here. And part of that is because hemorrhage and infection go back and forth between the fourth and fifth leading cause. And so it kind of depends on what resource you're looking at as which way those are listed. We talked about being less than 20, greater than 35, lack of prenatal care, low educational attainment. And again, is low educational attainment, is that related to socioeconomics, which relates to nutrition, which it's kind of hard to pick out one specific thing because so many things are tied together. The unmarried status and a non-white race, those are all risk factors in this pregnancy outcome. So what are the leading causes of neonatal mortality? And neonatal mortality is the death of our babies within the first 28 days of life. The leading cause is congenital anomalies such as congenital heart disease. They are born with an error that is incompatible with life or makes the health of this fragile newborn risky. And then below that are disorders related to short gestation, meaning our preterm babies, and our babies that are born at low birth weight. SIDS death, sudden infant death syndrome, respiratory distress syndrome, and then our newborns that are affected by maternal complications of pregnancy, such as our babies that are born because of mom's hypertensive disorder or because of her gestational diabetes. So let's look at socioeconomics. If they don't have insurance, then they may not have a job that they can afford to take a whole lot of time off. If they are told that they need to have bed rest, well, if their options are to go to work and earn a paycheck so they can put food on the table or pay rent, or stay home on pregnancy bed rest and risk losing their home, or risk not being able to feed their kids or keeping their electric on. Unfortunately, a lot of our women are in a very tough choice, and for some of them, they're going to choose to work so that they can provide for their family. If they're in this job without insurance, can they take the time off to go to the doctor's appointment? Depending on where you're at, you might sit and wait 2 or 3 hours because docs get pulled away from their clinic appointments to go to the hospital to deliver babies because our babies don't have calendars or watches and know, wait, we can't be born for another 3 hours until clinic's over. They can come at any time, so the physicians have to leave to go deliver, and so their offices get backed up. Can this woman take that much time off? If we're talking about that hospital in the rural facilities that we talked about, what if they have to drive? It takes an hour to get there. They have to wait for an hour for their appointment and an hour back. Well, their job allows them that kind of time off. Again, very tough choice. Do they work so they can pay bills, or do they go to the doctor, pay for the doctor at the expense of paying those other bills? Socio-demographic risk factors include low income, lack of prenatal care, their age, parity, meaning how many pregnancies have they had, the marital status, residence, and ethnicity. And why do we even care about this environment? Because that's where the baby lives. So everything that's going to impact mom is going to impact that baby's house for the next 9 months. Sometimes some of the things that our dads are exposed to can also affect this pregnancy because they have ongoing sperm development. So some of the things that they're exposed to can cause some structural damage to their DNA. And remember, this baby is half of dad's genetic material. Some of the environmental factors, remember, those can be things out in mom's environment or they can be internal to mom, which is the baby's environment. So things like mom's infections are some of her conditions, exposures to things in the workplace or out in the environment. We've talked about how age and the socioeconomics and sociodemographics impact the pregnancy. We've talked about age. Last week, we talked about looking at mom's OB history and her medical history. We want to know about any legal and illegal substances. And legal can be regular prescriptions that are just not as safe for this pregnancy as something else might be, whether she smokes or does alcohol, and what her nutrition status is. A congenital anomaly is a defect that is present at birth, and it can be caused either by genetics or by environmental factors. And a teratogen is a non-genetic factor that causes malformations and disorders in our fetuses. Last week, we talked about how frequent we're going to have appointments, what kind of things we typically do at that first appointment. So let's look at those a little bit. One of the labs that we have all pregnant women do is what we call a torch titer, and that looks at our torch infections. That's a group of infections that can cross the placenta and cause problems in our babies. They can affect the pregnant woman and or her fetus. They don't always have to have a visible outcome in our mom, but to impact our baby. And they have different effects on that baby depending on when that baby's insulted during the gestation. What's included in the torch titer? Toxoplasmosis, other, rubella, cytomegalovirus, and herpes. Our other infections typically include group beta strep, syphilis, our hepatitis, specifically hepatitis B, Coxsackie virus, Epstein-Barr virus for some providers, they'll test for that, HIV, varicella, or human parvovirus. The bacterial infections that we're most concerned about in pregnancy are chlamydia, gonorrhea, syphilis, or group beta strep. And our viral infections are HIV, herpes, cytomegalovirus, hepatitis A's and B's, and then the papillomavirus. All pregnant women should have these torch titers. A lot of our providers are going to test for gonorrhea and chlamydia. All of our pregnant women are tested for VDRL and RPR. Those are both tests for syphilis. And so one doc, depending on what lab they send their patients to, are going to do the VDRL. The other doc, using a different lab, they do the RPR to test for syphilis. Another lab that we do for our pregnant women is we do a urine culture. We determine if they have group beta strep or other type of infection, but the most common one is group beta strep, causing asymptomatic bacteremia, so asymptomatic urinary tract infection. And we treat them early in the pregnancy to get rid of that. And the recommendation is that we do rectal and vaginal cultures again at about 34 to 36 weeks. So we're not going to have results for some of our patients, our preterm labor patients. It's too early to test them, so we don't have those results. We're going to look at their hepatitis B surface antigen, and you might hear this referred to as HBAG, hepatitis B surface antigen, and that's going to determine whether mom's been exposed or if she's an active carrier of the Hep B virus. We're going to look at rubella to find out if she's rubella immune or not, and that's usually reported as immune or non-immune. Some of our providers initially check for other sexually transmitted diseases, such as chlamydia, HPV, or herpes. Some of our providers may only check for a certain group of women based on risk factors or based on symptoms. But it's important to understand that some of our STIs can cause damage to our fetus or cause preterm labor, and they may not have any symptoms. So if we're only testing based on symptoms or risk factors, we may miss some of those. We want to remind women about safer sex practices and risk reduction, remembering that if we treat mom, we also need to make sure her partner is treated so that she doesn't get reinfected because we haven't treated the partner. Reportable diseases that are required to be reported to the health department in the state of Texas include HIV, chlamydia, gonorrhea, syphilis, hepatitis A, B, and C, measles, mumps, pertussis, chickenpox, and rubella. Chlamydia is one of the most common bacterial STIs in the United States, and it's very frequently asymptomatic. It can cause PID, pelvic inflammatory disease, which can cause scarring of the fallopian tubes, which is going to eventually lead to infertility issues, and it puts mom at increased risk down the road for an ectopic pregnancy. It frequently coexists with gonorrhea and/or HIV, so we need to be testing for both of those. Untreated cases of chlamydia cause neonatal conjunctivitis or pneumonia. Gonorrhea is becoming drug resistant. We are seeing more and more cases of drug resistant gonorrhea in the United States. Again, this is frequently asymptomatic in women, can cause premature rupture of membranes, can lead to preterm birth, chorioamnionitis. And if you remember from last week, we talked about the membranes that are around the baby, the amnion and the chorion, that's a bag of waters. Gonorrhea can cause infection of those membranes, which can lead to premature rupture and preterm labor. Can cause neonatal sepsis, and it can cause intrauterine growth restriction in our fetuses. Gonorrhea can cause ophthalmia neonatorum. Our babies who are not treated can go blind from gonorrhea. This is why all newborns get erythromycin eye ointment soon after birth, is to prevent this. Syphilis is on the rise. We may or may not see the chancre in our women. Our women can present with primary, secondary, or tertiary syphilis. Our babies can be born with primary, secondary, or tertiary syphilis. This causes problems in neurologic, cardiovascular, musculoskeletal, or multi-organ systems. Our babies are frequently born infected. If mom has it, baby's going to have it. And the treatment of choice is penicillin. If mom is allergic to penicillin, then we can treat with doxycycline, tetracycline, or erythromycin or emycin. Doxycycline and tetracycline are contraindicated in pregnancy. However, that contraindication may be overridden because of the risk of not treating this infection at all in mom. And so sometimes we do use meds that are contraindicated because we know the outcome, if we don't use it, is much worse than the complications that might happen because we do use it. HPV, it is the primary cause of cervical cancer, and this can be passed to the fetus during birth. Sometimes in our young women, this may resolve without treatment, but there's no effective treatment to get rid of the infection. There are 2 vaccines that are available to prevent the most common subtypes. And I frequently hear, well, that vaccine's only good toward 2 of the many, many types of HPV out there. And while that's true, the 2 types that it does prevent are also the 2 leading causes of cervical cancer in our women. Herpes is often asymptomatic in our moms. They may have general symptoms and not realize that they've been infected. They have malaise. They have other signs and symptoms. They're achy. They're tired. That's also signs and symptoms of pregnancy, so they may not see this as an abnormal symptom. They may or may not have lesions that are visible. Important to understand that oral herpes can be transferred to genital area. Genital herpes can be transmitted to the oral area. So just because it's in one of those areas, we still end up typically subtyping those to find out exactly which infection we've got. The primary outbreak, if she has her primary outbreak the first time she's been exposed during the first trimester of pregnancy, sometimes it causes such severe manifestations in our fetus or our embryo that it actually results in a miscarriage. It can cause neonatal herpes, and that can be fatal to our babies once our babies are born. There's no known cure. However, we do use systemic antivirals such as acyclovir. What we don't know is exactly how safe that is during pregnancy, but we also know the outcome if we don't use it, such as this neonatal herpes that can be fatal. If mom has lesions present when she comes in for labor, she will have a cesarean delivery. But if there are no lesions present, it is safest for her to have a vaginal delivery. Hepatitis, the main one that we're concerned about in pregnancy is hepatitis B. Like we said, we test for the hepatitis B surface antigen in all of our pregnant women if they're getting prenatal care. If that's positive, we tend to do more testing to find out if she's a carrier, if this is a recent infection, if she's actively infected. If a definite exposure is known, then we're going to give mom the hepatitis B immunoglobulin, and we're going to start her immunization series or update it if that's what's required. If mom is HBAG positive, then baby's going to receive the immunization and the immunoglobulin once baby is here. Mom can breastfeed if she's hepatitis B positive as long as the baby has been immunized. We all know that HIV is frequently asymptomatic in the initial time frame, and it can be asymptomatic for many, many years. It is transmitted to the fetus through the placenta, through the mom's blood, through breastfeeding, through labor and delivery, or from ingestion of maternal blood and through breast milk. That being said, we will do a C-section if the viral load is extremely high. If we have her on systemic antiretrovirals during the pregnancy and have a low viral load, it is safest for this baby to deliver via vaginal delivery. Yeah, but that's a lot of blood and the baby's passing right through that. There's a lot of blood and baby's passing right through that during a cesarean delivery as well. And so it is safer, there is less risk of contamination and less blood involved in a vaginal delivery compared to a cesarean delivery. There is no known cure at this time. And our infants, once they're delivered, we tend to put them on antiretrovirals as well. And so if mom is treated during her pregnancy and we get her load down, baby is delivered and we put baby on the antiretrovirals, then transmission to our fetus is very, very low, and to our newborn is very, very low, and they may not be infected at all. We talked about group beta strep earlier. It can cause a severe or fatal infection in our newborn. That's why ACOG recommends that we test all of our pregnant women at 34 to 36 weeks and to treat those while they're in labor if they come out positive. Now, we do know that there are, like Parkland, for instance, they don't test their pregnant moms, but they treat all newborns as they come into the newborn nursery. And part of the philosophy behind that is they have a very large indigent population, meaning that they have a lot of women that come in to deliver babies that have had no prenatal care, or they drop in, and so they don't have prenatal records. And so rather than risk somebody missing a mom who wasn't tested, or we don't know what the test results are, they felt like it was just safer to give an antibiotic shot to all newborns as they enter the nursery. And that has worked out well. And because of their research along these lines, we may see that the standard of practice might change. Now, in most cases, we don't want to treat an infection if we don't know for sure that we have the infection. And that's true in anybody but our newborns. In our newborns who have the potential to be infected, or who are showing signs of infection, we are going to treat rather than wait on a result, because by the time we get those results back, we may have lost our baby. Group beta strep, we treat with penicillin G or with ampicillin while they're in labor. Other environmental factors that we want to look at is mom been exposed to radiation, to chemicals such as mercury or lead or other industrial pollutants. What about substance abuse? All medications, legal or illegal, all substances that mom takes into her body cross the placental barrier. There's a frequent comorbidity with drugs and mental health disorders. Many female substance abusers were sexually abused as children. Current substance abusers are frequently in an abusive relationship at the current time. And so we have to ask, what came first, the substance abuse or the drugs? Are they using drugs to deal with the fact that they were abused as a child, or they are currently being abused? Or are they living in a situation that abuse is going on and there is substance abuse in that environment? So they just kind of go hand in hand. Are the socio-demographics of substance abusers similar to those for violence? What we have to realize is that there is abuse across all socioeconomic statures, across all income levels, as well as substance abuse. So it's not just a very wealthy problem or a very poor problem or an inner city problem or a rural problem. It's a problem across all of our patient populations. Secondhand smoke, either from cigarette smoking and probably from marijuana smoking, decreases blood flow through the placenta, and that can result in a low birth weight infant. And remember, we talk about these low birth weight infants. I want you to hear when we talk about low birth weight infants, those tend to be sicker infants. They have been more stressed. These are not healthy newborns if they're low birth weight. This smoking that decreases the blood flow through the placenta can increase the risk of preterm labor, perinatal death, and perinatal death means that they die in that labor and delivery. So these are our stillborn babies. And then they are at increased risk for SIDS. If mom smokes throughout her pregnancy, but never smokes another cigarette once that child is born, we do know those babies are still at higher risk for SIDS death compared to those babies whose mom did not smoke. There's increased childhood lung ailments. We know that our smoking cessation material that we have for our moms are more successful if they are directed at pregnant women as opposed to the population as a whole. If the education pamphlets and the posters that we have in our clinics, if those are showing 80-year-old men, 75-year-old women, teenagers, male patients, we know that that's not as effective as if all the materials are directly related to smoking during pregnancy. We need to talk to our women about these at every appointment and encourage her at every appointment. For every one cigarette she doesn't smoke, that's one little bit healthier of a pregnancy. So if we can encourage her even to decrease the amount, even if she can't come to completely quitting, it still can lead to healthier outcomes than if she didn't try at all. Some of our moms are very, very successful at quitting smoking while they're pregnant. They find out they're pregnant, they don't have another cigarette. And we need to encourage them and be, cheerleading them on for that. Smoking cessation is very hard. And if they have quit, we need to talk to them about that on postpartum. We need to talk to them about that at the 6-week postpartum checkups. Because unfortunately, 60 to 70% of our smokers who quit smoking while they're pregnant are going to start smoking again in that postpartum time frame. And if they've managed to successfully quit for that 4, 5, 7 months, we need to encourage them to stick it out. They've got the hardest work done. Just keep doing what they're doing. It decreases fertility in both men and women. Be very careful how you phrase this around teenagers, because I've made this statement in talking with teenagers and had them go, oh, so if I smoke, I can't get pregnant. No, smoking is not a form of birth control, but it can decrease fertility. It increases the risk of cancers. It does age that placenta prematurely, so that instead of being healthy for 40 weeks, it may wear out before that, and it's not providing the gas exchange throughout that entire later part of the pregnancy. It leads to our lower birth weight infants. It exposes the partner and later the infant to the secondhand smoke. Smoking does increase the risk of spontaneous abortion, preterm birth, placenta previa, placenta abruption, or premature rupture of membranes. And we're going to talk about previa, abruption, and premature rupture next week when we talk about our high-risk pregnancy conditions. We know that alcohol increases risk in pregnancy. Alcohol is the leading cause of preventable mental retardation in the United States. I want you to hear that one more time. Alcohol is the leading cause of preventable mental retardation in the United States. It causes fetal alcohol syndrome, fetal alcohol effect, typically the same thing. Maybe in some research there is a difference in that, but these are inborn issues and anomalies in our babies specifically because of the alcohol they were exposed to in utero. We need to be very careful and non-judgmental when we're talking about alcohol and substance abuse and smoking with our moms. Remember, if this is an addiction, part of the addictive behavior is that the need for whatever they're addicted to is more critical than the outcomes of being exposed to that. So we need to be non-judgmental. We need to talk to them about how to seek treatment, make referrals for treatments. If they are drinking and they're actively drinking, of course, they're at more risk for motor vehicle accidents and drunk driving and any of the damage that can cause. A lot of our women who have, or not just women, a lot of the patients that have chronic alcohol use are also depressed. And then again, we have to ask which came first, the drinking, and they are depressed because of the drinking and because of the changes that the drinking has on their brain tissue, or were they depressed and that led to the drinking to deal with the depression? We know that our drinking women who are alcoholics or are dependent on that alcohol have higher rates of attempted suicide. And women 35 to 49 are the highest risk for chronic alcoholism. And we do have women in that age frame getting pregnant. Again, we said leads to fetal alcohol syndrome, fetal alcohol effect, or fetal alcohol spectrum disorder. We don't know of a safe amount during pregnancy, so we still recommend abstinence. So is it worth it? If we can see, I don't know if you can see this. This is a normal brain here on the left-hand top. The picture right next to that, do you notice the difference in those brain structures? The one on the left is a normal brain. The next one is a fetal alcohol baby. The center pictures in that top row, the top picture is a normal brain compared to the fetal alcohol spectrum disorder brain in this lower picture. Fewer brain folds, smaller head size, smaller brain surface, underdeveloped inner brain. They don't have the same brain matter that a normal baby's going to have. So that will be lifelong problems. If that structure is not there during development, they are not going to develop this later. It's not something they can catch up and make up for once they're born. And then these bottom pictures are the pictures of the babies that actually have fetal alcohol syndrome or fetal alcohol effect or whatever we're going to call that. They have very specific characteristics of fetal alcohol syndrome. The small head circumference, simple form low set ears, thin upper lip, a small chin, small eye openings, a flat midface. Very, very specific criteria to meet this. And a lot of times, unfortunately, you can tell as soon as this baby's born by looking at them that they are probably a fetal alcohol syndrome baby. Sometimes it's just a matter of teaching and talking to our moms. Sometimes we have moms that come in, they're 6, 7, 8 weeks along. When they come in, it's like, oh my gosh, I've been drinking. What now? All we can tell her is that from here out, please limit your alcohol. Please try to not have alcohol. But we can't undo whatever damage might already be done. And so again, going back to that prenatal, preconceptual appointment, we need to be teaching women who are of childbearing age about the effects of alcohol during pregnancy. You have to be careful. How willing are they going to be to admit this? If we're very judgmental, I mean, we're not going to say, you don't drink, do you? We need to be non-judgmental. They may be afraid to admit about drugs, alcohol, abuse, smoking, for fear of losing custody of the children they already have, or fear of losing this custody of this child as soon as this child's born. We do know that a lot of these women might be late or have no prenatal care. And so a lot of our hospitals will do a drug screen on mom and baby if mom shows up to deliver a baby and they have no prenatal care. It's just the standard to do a drug screen. They're afraid of being judged or of criminal prosecution. Some of our states will arrest moms and put them in jail if they know that they're doing drugs while they're pregnant. It doesn't matter what your personal opinion about this is. There can be some very pros and some very cons to that. The pro is hopefully it does decrease how much they're being able to consume. The con to that is prison is not a drug-free or alcohol-free place, no matter what people want to think. And another con to that is, are women going to admit that they're doing drugs or alcohol if they know that they could face criminal prosecution? So it may prevent them from seeking the help that they need. Caffeine, we talked a little bit about last week when we talked about nutrition. We do know that it decreases iron absorption, and it can cause a miscarriage or increase the risk of a miscarriage. It can interfere with appetite and nutrition because it competes for receptor sites for some of the nutrients. We don't know the exact effects of marijuana on pregnancy because it's very hard to do research on that. Frequently, all we can do is say, oh, you admitted to having marijuana and look at the outcome. But we can't do pure research. We can't say, okay, you group of women over here, y'all smoke, y'all over here don't, and let's just see the difference in the outcome. That's not ethical. So we're never going to see that type of research. And part of the difficulty in researching this is, are marijuana smokers also smoking cigarettes? Are they having other alcohol? Are they doing other drugs? Or are they the only thing that they're doing that is not healthy is just the marijuana? And that's based on self-report. We do know that it can cause some maternal anemia and poor weight gain in our moms, leading to intrauterine growth restriction. We know risk for cocaine is that mom can have an MI or cardiac arrhythmias, ruptured ascending aorta, they can have seizures, they can have sudden death, increases the risk of abruption preterm birth. SIDS death can cause neonatal withdrawal in our newborns. We do know that our babies have genitourinary anomalies and heart defects because mom did cocaine during her pregnancy. So we do know specifically that cocaine does cause some of our fetal anomalies. And so that's the end of this lecture.